Perfect. Well, hello. Good. I almost said morning. Mental status check. Good afternoon. My name is Danelle Hupp. I am a clinical psychologist by trade at the Best Center at NeoMed. I am the senior consultant and trainer for family-based services and also a clinical associate professor of psychiatry here. So I really appreciated being invited by Nicole and Jamie to chat a little bit about a model I think they've heard me talk about once or twice before, but it's something called REORDER, Recovery-Oriented Decisions for Relative Support. So it's a strategy to engage loved ones in care. And so that's what we'll be chatting a bit about today. We'll talk a little, very briefly about the rationale for engaging loved ones in treatment. And then we'll just go over the reorder model. When you get a copy of the slides, the manual will also be sent out as well so that you can have that. It's a very short manual. It's more like a guidebook. So engagement of loved ones. I think most of us here in the room, know the importance or recognize the importance of engaging loved ones in care. When an individual or a family member, broadly defined, however the client identifies their family members or loved ones, but when that individual is supportive and knowledgeable, their outcomes improve, and not just for the client, for the family as a system, and for individual family members as well. So you see people getting back to living their lives, the client and the family members. You see people that are more adherent to treatment, including medications, which means fewer returns and rehospitalizations. That means decreased costs of care, fewer symptoms, but you also see people getting back to work, engaging in social activities. All those things that we really hope for with the individuals with whom we work, and family is just another avenue to help us get there. So even though the research has been around for about 40 years at this point about the important role that family and loved ones do play in treatment, family services are still pretty limited and they're pretty minimal. And there are a lot of this because there are quite a few roadblocks. If you think about how you bill for this time, the extra time it might take to engage a family member. Family members may not recognize that they have a role to play in treatment. They may think, well, I make sure she takes her medication. I make sure he gets to his appointments. What else should I be doing? As providers, we may not recognize how important and critical it is to engage them in an ongoing kind of way in our treatment. And an individual may have confidentiality concerns. They may be too symptomatic at present to feel comfortable engaging families. So lots of family dynamics obviously can come into play. So lots of reasons that it can be difficult, but we know that it's important. And when it happens, that it works. I think, when I was researching a couple years ago that, we know that about 20-ish to 25% of individuals will return to the hospital within a year. If they do not follow through with an initial outpatient visit following a hospitalization. And we also know that families play that critical role in that transition from inpatient to outpatient services, but minimal contact occurs between the provider side and the identified family member or loved one with individuals living with schizophrenia. So in less than half of the cases, there's very minimal contact, which may mean just, here's an appointment reminder. Does he need a ride? More than half of the time, there's no contact. And, individuals living with schizophrenia specifically are some of the highest need for those to have sort of wraparound and a full network around them to engage them. So what if there is ambivalence or hesitation to involve loved ones or to be involved as a loved one? How do we overcome some of those barriers? I just, named a couple. And this is where this reorder approach or the reorder model can really come in. So we know that the Schizophrenia Patient Outcomes Research Team, which was, written back in, I think, 1992 or 94 and has been revised a number of times, but something that always remains in there is the importance of involving family members. Ideally in a longer term evidence-based intervention for, most bang for your buck, but shorter term interventions, at least 4 sessions in less than 6 months of time, you can still see outcomes improving, even though it's not as robust as somebody who's engaged in formal family psychoeducation for 2 years. So this recommendation by the Schizophrenia Port has consistently been held alongside CBT and various medications. And they do recommend that, and we hope that these shorter term interventions are really a bridge to the longer term, more involved, more structured, evidence-based interventions for loved ones. But this is really the lane where reorder comes in, and hopefully where some of you may be able to use this approach in your work. So reorder is a really brief intervention. It's just 6 sessions. It's structured and manualized, and I'll share a little bit more about that, but it's actually really beautifully done. It promotes recovery and encourages the individual to consider involving a loved one, however that person defines loved one. So it doesn't mean that they're required to engage them, but it's just starting the conversation, which is sometimes the most difficult part. It defines loved ones broadly and inclusively, and it can be really that precursor to the more intensive or more consistent loved one engagement in your work over time. The primary goals of reorder are to provide a recovery-oriented approach that optimizes involving loved ones. So really staying focused, what goals everybody has, how the family members can support the individual's goals, supporting a client-centered shared decision-making model. And this starts from the very beginning, where it's up to the individual in treatment if they choose to engage or approach a loved one to invite them to treatment sessions, and for how long and how involved they want them to be. And it increases the likelihood that loved ones will participate in a more constructive kind of way. You know, a lot of the feedback that I've heard, I've been here just under 12 years. And so a lot of the feedback that I heard is that things seem to fall on a continuum, but usually when it comes to families, it's one end or the other. So we see under involvement, lack of engagement, or really hyper involved, kind of overtaking the treatment, monopolizing treatment. And so we need to help them fall into that sweet spot of family engagement. And this is one step in that direction. Why it works. It's very user-friendly to us as providers. It's structured, but it's flexible. And the piece that I love that I think is so well done is that, you know, there's a lot of rehearsal, role play practice that happens with the individual to gear them up and get them prepared to request that a loved one join them in session. But it also provides sample scripts. So as providers, if we don't know how to start the conversation, we're not sure, you know, where to go if an individual is is a little hesitant to involve a loved one versus somebody who's really excited to involve loved ones, but they're not sure how the loved one might respond. It gives lots of different options for various scenarios. So very nice sample scripts to help us feel comfortable both having the conversation at the beginning with the individual in treatment, as well as once family members or loved ones start to engage. And it provides nice structure and agendas. It truly is client-driven. There's shared decision-making involved, which all of us are familiar with. It takes this sort of gentle, unassuming approach that, you know, here's this idea. What do you think? Where are you at with that? Let's hit the pause button. We can always come back to it later. But because of the short number of sessions and its structure, it does feel very manageable and palatable. To us as providers who are busy and don't really have time to learn a whole new protocol, this one feels very, very manageable as a way to as an sort of an engagement strategy and a discussion starter with individuals and their loved ones. So there are 2 phases. Each are 3 sessions, one in which you work for 3 sessions with the individual or the client. And then the next 3 sessions involve the family or the loved ones. And the first session with the loved ones are just with them to give them the opportunity to have some one-on-one time or small group time with the provider. As long as the client is comfortable with this. But then the second and third sessions may include the individual depending on what the goals are. It's time limited, as I said, 6 sessions, and it's just provided over 2 months for about the typical treatment hour, 45 to 60 minutes. What you would need if you chose to, incorporate this into your work would be the reorder guide or the manual, which will be, sent around to you. Some training, so some review of the manual, how it works. It's rooted in motivational interviewing and shared decision making, so ensuring that you feel comfortable and familiar and confident in those domains. Having a genuine interest in involving loved ones, I think, is very, very important, before you start the conversation, and really sort of doing some self-reflection about what might this look like or feel like for me as a provider, if this is something that you don't always have the opportunity to do, if there are time constraints or different things like that. Really important to do a bit of self-reflection about how you might use this and what longer term engagement a family might like if somebody wants to continue to have them involved. And then, some knowledge about barriers and facilitators to engaging loved ones, because you're not going to get full steam ahead every time that you approach a client or every time the client approaches their family. There are going to be some no's thrown your way. So the phases, just very briefly, a little bit more detail. In phase one, this is that collaborative discussion about recovery goals and who, might in their support network really might help them to be able to reach those goals, and in what ways. I think that that's a very important piece of the puzzle. In what ways could that particular individual assist in helping you reach your recovery goals? And normalizing and validating any concerns or hesitations that they may have about involving loved ones, validating, normalizing, that, it could go right and it could go wrong. And what are some of the potential, downfalls or pitfalls of involving this particular loved one? And do we feel like this is a good time? What are some things that we can do to prepare to engage them? So discussing and validating those hesitations. It really empowers us as providers. It really empowers the provider to empower the individual to invite that loved one if they've been hesitant because they're a little nervous about what that individual might say or do or decline. And then we work with them on their skills to help them advocate for involving loved ones in other domains of treatment. So if you are, working in social work and you're doing counseling, and that individual would like to invite their family members to a med appointment, but they're not sure how to start that conversation with the provider or the family, you can really assist in helping them to find that language and then helping them to figure out how to advocate for that. So I just put up here so that you would have, some idea of what the reorder approach is, but, it gives those options. If somebody is living with their family, here are some of the highlights of things that you might want to discuss when you're first introducing the idea of engaging family to the client. If they're not living with family, but they can identify someone, versus if they're having a hard time identifying who that person, that trusted other might be that they could engage. So it really, or if they have too many people and they want to invite everybody. So it really does lay out, and these are just little snippets, but it really does give you a nice guide as ways to initiate conversations based on what you know about this individual's relationships with others. Examples of techniques that I think we all do pretty often, but that can very nicely align with the work of REORDER. Obviously, alliance building with the individual and family. Problem solving and behavioral rehearsal, you'll be doing a lot of. Personal decision guides or decision aids that you can use with an individual to help them weigh the pros and cons of option A and the pros and cons of option B, rather than just the typical pro-con list. Those are wonderful. There are a lot of them. I put the link here so that you can visit that website. They're really nice guides that you can use across the board about any decision. Medication, yes, no. Pros of taking medication, cons of taking medication. Pros of not taking medication, cons of not taking medication. So, a decision guide can be really useful in, figuring out the pros, cons of involving versus not involving loved ones. And then values clarification. So what matters most to that individual, and how can their people that they feel play an important role in their lives be supportive of that? Where might there be differences that lead to tension and conflict? Where might there be shared opportunities for things that matter to them or things that they value? And so there's a very nice clarification values exercise that I also linked to here, and they're in the references as well. So phase 2 of REORDER, the loved one intervention. So if the loved one accepts that invitation, the focus is really initially on engaging them, getting to know them, what's their perspective of their relationship with the client. They get some basic psychoeducation and tools, especially in that first session. And it helps them to collaborate more effectively, not just with the client, but with the treatment team as well. This is an opportunity to provide them with referrals that you may have for support from the organization, from things like NAMI, National Alliance on Mental Illness. And it offers, the REORDER manual does offer alternatives depending on how knowledgeable and how engaged loved ones are able to be at this point in time, and how knowledgeable they already are about the individual's illness. So, if somebody is a little bit ambivalent about participating, or they're really not engaging in loved one's treatment, they really will talk and walk you through the MI approach for that. If you have a pretty savvy family who's already well engaged, they may not just be participating in sessions with you yet. They have some other more advanced education that you can get some ideas for where to go. So again, some of the conversations that, defining recovery, if people aren't defining recovery in the same way, somebody's going to be disappointed and somebody's going to be left frustrated, because if dad says, recovery is when he's on no medication and back at school, and mom says recovery is when he's moved back home and I can see he has no symptoms on his medication, and client is somewhere in between, and nobody's on the same page. So we're just sort of stirring the pot of chaos, and we're really contributing to levels of frustration and disappointment, and which can lead to resentment amongst family members if we aren't all on the same page about what recovery means. So this does a nice job of helping to initiate that discussion as a group with the family system. So some techniques that are really applicable with that, and that align nicely with reorder. Again, alliance building, communication is very important. Obviously, when you're working with family systems, especially in the second phase where families coming in, talking about expectations, belief systems, the importance of using summaries and restatements. So people hear things through neutral ears and they're not already preloaded to have an idea that this is going to be coming from a negative place. If you can restate what you've heard and clarify with the deliverer of the message that this is, is that accurate what I heard? And then clarify with the recipient if that's what they heard, that can be a really useful tool for families who, especially where there's a lot of tension and frustration. And then obviously education and referrals. So there has been some initial research done with reorder. This initially came out of the VA. And, in this group compared with treatment as usual, they did see some reduced paranoid ideation. Scores were improving for individuals who really had this feeling of being stuck, which is one of the aspects of when, you're measuring recovery. And there was this robust impact on family involvement, which is why I always like to bring up reorder as an option to include in your practice, because 52% of families from reorder versus just 13% of those with treatment as usual, even with an enhanced plan for family involvement, you would still see the greater numbers that they were participating actively and completed the sessions. So, something that's worth consideration. Take a look at the guidebook, see if you have questions on it. Happy to answer any questions, talk about it, think through how you might want to use it in your practice or how it might fit for you given your various roles. I am always available, so I made sure to put my email on here. So any questions or thoughts?